Hi, I'm Giuseppe from Rome, Italy, and I want to thank you very much, the organizer and all you, the audience, for giving this opportunity to share some information about the infection which has changed the world in these few months. The virus, which is responsible for COVID-19, the SARS CoV-2, has been shown to cause a constellation of symptoms affecting multiple organ systems. One of the earlier and more dramatic findings has been the association with an acute inflammatory syndrome. We will review together the possible life-threatening immune events that can occur during disease progression to uncover the key factors behind severity of this infection. As you have just heard, hematological changes are striking in COVID-19. We have an early lymphopenia, which can be due to infection or killing of the cells, but also to tissue margination and infiltration. We have an increase of Th17 cells and also of CD8 positive T cells with cytotoxic granules, which contain substances which are very damaging cells like perforin or granulicin. And at the transition toward severe forms, neutrophilia and increasing D dimers are common with a variable incidence of thrombocytopenia. When ARDS develops, we see increase of C-reactive protein, LDH, ferritin, procalcitonin, all inflammatory markers, interleukin-6, and other cyto or chemokines. And DIC, coagulation, intravascular coagulation, manifests in many of the patients who die. Many studies have now reported the association and progression and death with virus-induced hyperinflammation. The virus is the trigger, as you see in this editorial in Lancet Journal, but the immune response is deadly. Even if direct evidence is still lacking, it is certain that the manifested clinical features are directly related to a multi-system inflammatory syndrome, which has been described, as you see on the right, even in children and adolescents. What we know today about this link between hyperinflammation and COVID-19? Well, the virus has been shown to cause different symptoms, from mild upper respiratory disease to severe pneumonitis and even ARDS, multiple organ failure and death. The disease is multifactorial and is associated with immune systemic activation, which is both specific antiviral and innate inflammatory response. Their extent may determine why some individuals are asymptomatic and others develop serious complications. Then pro-inflammatory cytokines, we will see IL-6 and others, drive the response of the immune system during progression toward the severe stages. And a dramatic finding is the association of these cytokines in what we call a cytokine release storm. And certain patients have a clinical picture which is consistent, as we will see, with secondary hemophagocytic lymphohistiocytosis. And so important is the immune reaction that antibodies targeting IL-6 activity are now used in the treatment of severe patients. The cytokine release syndrome is a hyperactive and dysregulated immune response with overproduction of inflammatory cytokines from a variety of cells, mainly immunological cells. Among these, we see interferons, interleukins, tumor necrosis factors, chemokines, that is, cytokines which determine cell chemotaxis, and other mediators of the innate immune response with interdependent biological activity without a negative feedback on the immune system. And they cause an almost, we can say, autoimmune injury to the host cells with acute lung injury, respiratory distress, acute kidney injury, and multi-organ failure. So the hyperinflammation in COVID-19 is characterized by increased plasma levels of a large number of inflammatory cytokines, more than in the other known severe coronavirus infections. And we see that there are a lot of cytokines here on the right, growth factors, monocyte chemotactic protein, monocyte inflammatory protein, TNF, interferons. High serum level of interleukin-6 have been reported to be significantly associated with death. And it's on this basis that several authors have suggested that the immunological profile of severe COVID-19 resembles that of the cytokine release syndrome. A few words about the entry of the virus and replication of the virus within the cells. The virus enters the human body by inhaled respiratory aerosols and droplets or contact with surfaces contaminated. Then you see binds to the angiotensin converting enzyme 2, ACE2, expressed on cell surface via its spike S protein and penetrates the host cell on activation and catalytic activity of the cellular transmembrane protease, TMPS2. The interaction of the S protein with the ACE2 cellular receptor may result in the dysregulation of the renin-angiotensin system and result in increased vascular permeability, lung edema, inflammation with influx of neutrophils. We know that marked neutrophilia with morphological ATP and immaturity develops in patients with severe COVID-19, and infiltrating neutrophils and macrophages have been found in the tissues, especially in the lungs of patients who die of COVID-19. These cells contribute to the lung inflammation and tissue damage, to vascular complication of many organs and death of the patients. Upon infecting the cell in the respiratory tract, the single-strand RNA structure of the virus is recognized by a receptor, a class of receptor which are named TLR, Todd-like receptor. Especially TLR7 is important. And the virus is recognized, and within endosomes on the cells leads to the induction of pro-inflammatory cytokines and interferons. So the combination of this TLR7 with the virus initiate a cascade amplification that leads to the activation of multiple intersecting cytokine pathways. In most individuals, this immune response is sufficient to clear the virus and prevent the severe disease. In other individuals, however, the immune system does not clear the virus, leading to viral replication, as you see here, and death and spread of the virus. In other individuals, an overactive immune system may control viral replication, but result in collateral damage to tissues. All these scenarios insufficient to control viral replication and exuberant immune response may lead to the severe respiratory disease and the final organ failure. Complex disease, which involves both cellular and humoral immunity. The antibody response against the nucleoprotein of the virus and the spike protein epitopes, both IgM and IgG, have been observed. Neutralizing antibody have been detected in plasma of convalescent patients. So humoral responses are mounted rapidly in COVID patients, at least in a majority of them, and could play an important role in the protection. However, the different potential role of antibodies in COVID-19 is still under debate. We don't know if the humoral response determines protection, long-term protection, or maybe exacerbation, worsening in some cases of the disease. However, the principal aim of my presentation today is to describe again the immunological events that lead to cytokine release syndrome and COVID-19 severity. And it is the innate immune system which provides the first line of defense against the virus. So we have a viral RNA recognition by the innate intracellular immune sensors like TLR receptor, generation of the interferons and cytokines. Some of them are especially important. IL-1 beta is a marker of severity, IL-6, interferons, etc. And the one we have seen in a few slides before. An important role is also played by further recruitment of T cells, especially Th17, which was related to immunity, autoimmunity, monocytes, dendritic cells, neutrophils, complement the components expression, and finally, epithelial and endothelial cells death leads to the release of a group of substances known as damage-associated molecular patterns, or DAMP. These are immune molecules from the cell, such as oxidized phospholipids or lipopolysaccharides. This is about pyroptosis. Pyroptosis is a pro-inflammatory form of programmed cell death, distinct from apoptosis. This is a schematic representation of a possible signal intracellular mechanism which lead to cell apoptosis, which is this specific form which is called pyroptosis. It is induced by the interleukin-1 beta activation of the Todd-like receptor, and also by pathogen-associated molecular patterns, or PAMP. TLR recognizes these extracellular pumps, as you can see here, and DAMPs also. And then the interleukin is present in pre-molecular form as the pro-interleukin with another receptor in the cytoplasm, which is the node-like receptor, or NLRP3, and the pro-caspase-1 form a multi-protein complex, which is called the inflammasome, and is the cytosolic multiprotein oligomer complex of the innate immune systems. This leads to activation of caspase 1 here, which in turn cleaves the pro-interleukin 1 beta and pro-interleukin 18, forming the active forms of these molecules. You see them here, which are released outside the cells, even because the active cleavage fragments of these pro-cytokines activate the gasdermin, which causes swelling, cell swelling, perforation, and lysis of the cell. Everything is then released outside the cells, and cytokines and other danger molecules. A compromised RNA specific innate immune response at the beginning of the infection could compromise control of virus replication, leading to a dramatic increase in the viral titer and the number of infected cells. Epithelial and endothelial cells will actively replicating virus will eventually become apoptotic or pyroptotic and die, further contributing to tissue inflammation by releasing their high levels of interleukins and other damps to the extracellular environment. The viroporin 3A is a viral protein which is present in the genome of the SARS CoV-2, which is capable of inducing the direct activation of the NLRP3 receptor in the inflammasome within the cell, resulting in further pyroptosis with cell perforation and lysis, with mass release of pro-inflammatory cytokines, chemokines, and DAMPs. The different evolution and disease severity can be explained by the immunological events which follow infection. This relates to the capacity of the immune system. Patients who have a reduced immune system can have a dysregulated inflammasome activity with more tissue damage and up to the cytokine store release, neutrophils, macrophage, and differentiation of T cells as Th17, all producing cytokines and other inflammatory mediators. There is no time here to illustrate all the different scenarios, but for example, here on the left, after exposure to a low viral load, the innate immune response can be okay without necessity to raise an adaptive immune response. In this case, there is lysis and phagocytosis by NK cells and macrophage, enough to clear all infected cells. In other cases, there is a necessity of activation of the adaptive response. There is, in this case, antibodies are produced and the response is more complete. But in the worst possible scenario, here on the right side, the innate response is not able to clear the infection and the patient is unable to mount a complete adaptive response, so that the virus will propagate and massive destruction of affected tissues will occur. Cell-to-cell interaction is also very important, as recently shown in this paper in Science by Moore and June. Cytokine release syndrome is common in these patients, and a high serum interleukin-6 correlates with adverse clinical outcome. High serum CRP, C-reactive protein, whose expression is driven by interleukin-6, is also a biomarker of a severe form of the disease. In short, infection of monocytes and macrophages here, and dendritic cells results in their activation and secretion of more interleukin-6 and other inflammatory cytokines. According to the Moore and June paper, this cytokine release syndrome might be treated with interleukin-6 antagonist, such tocilizumab or sarilib. Hemophagocytic lymphohistiocytosis. This is a severe, life-threatening inflammatory syndrome which is associated with intense cytokine release, or cytokine storm, if you want. Similar to COVID-19, HLH is characterized by aggressive course leading to multiple organ failure. In adults, HLH is secondary, is almost most commonly triggered by severe viral infections, but also in patients with leukemia receiving engineered CAR T cell therapy. In addition to high serum cytokines, high concentration of ferritin are characteristic of this disorder, and this is known also as macrophage activation syndrome. Well, tissue damage in COVID-19 has been assimilated to secondary HLH by several authors. In both conditions, in fact, there is an overactivation of cytotoxic T cells with hemophagocytosis by macrophages and the massive release of these cytokines, etc. And clinical characteristics of COVID-19, in effect, also resemble those of the secondary HLH. The cardinal feature are high fever, hepatomegaly, splenomegaly, coagulopathy, central nervous system disturbances, and rapid progression to multi-organ failure. Respiratory symptoms are also present. This phenomenon mostly occur in cases triggered by respiratory viruses and CAR T cell therapy. And the signs of infections can overlap with the symptoms of HLH. So indeed, the number of cardinal clinical and laboratory features between these two conditions, HLH and COVID-19, are similar, and it is summarized in this paper by Opoka et al. In a table which is obviously too big to discuss now, and which continues here in this other page. In terms of laboratory findings, we have already mentioned how these conditions are associated with thrombocytopenia, coagulation disorders, hypofibrinogenemia, and raised dimer, altered liver test results, increased LDH resulting from cell destruction, hypertriglyceridemia, which also derives from cell destruction, increased ESR and CRP, increased ferritin, which comes from the macrophage, and hepatocytes, which secrete ferritin. And according to these authors, all patients with the COVID-19 should be screened accurately for hyperinflammation, and also the HS score, which is the hemophagocytic score, based on this laboratory marker and clinical symptoms, should be used to identify the subgroup of patients for whom immune suppression could decrease mortality. Therapeutic options so include steroid intravenous immunoglobulins, selective cytokine blockade like tocilizumab. So immune suppression can be useful in this sort of patients. This theory of a cytokine release syndrome is not unanimously accepted, however, and there are several criticisms. In effect, interleukin-6 is a key mediator, and both ILS and other cytokine levels in severe COVID are high, but not so high as in ADRS from other causes. For example, in CRS following CAR T cell therapy, plasma interleukin-6 levels are 1,000-fold higher than in COVID-19. In addition, severe vascular injury, including the formation of thrombi in the microvases, is frequent in post-mortem reports of COVID-19 cases, and probably more specific mechanisms of COVID-19 lung damage still have to be identified. Hemophagocytosis, however, we don't know if it is the main syndrome or it is one aspect of a more complex clinical picture. However, hemophagocytosis is visible for hematologists like we are in bone marrow. In this study by Prieto Perez and colleagues, post-mortem pulmonary and bone marrow biopsies, as well as bone marrow biopsies in 3 live patients, have shown striking lesions of histiocytic hyperplasia with hemophagocytosis, and which is the histological counterpart of the macrophage activation syndromes or secondary HLH due to the massive release of inflammatory cytokines. Bone marrow sections of these patients showed increased cellularity here and striking hemophagocytosis with many scattered macrophages that engulfed erythrocyte and erythroblasts. And macrophages are visible here because they are CD163 positive. And would also in the double staining with glycophorin, you see very well here the phagocytosis of red cell and red cell precursors. And so this beautiful microscope image is my last slide. And thank you very much for your attention and your questions. Thank you.